you all. So why osteoporosis in this talk about rheumatology? It is a even common part, and it is very important because it is a wide area wherein you have osteoporosis in younger people, which is pathological, as well as in older people, which is more of postmenopausal. So according to AACE guidelines, those with osteopenia or low bone mass and have a history of fragility fracture are to be treated. Those with a score of less than 2.5 in the lower spine, femoral neck, or total hip are to be treated for osteoporosis. And those people who have a T-score between -1 to -2.5, which is osteopenia, but a FRAC score, 10-year probability of more than 20% are to be treated. So risk categorization and treatment accordingly to that is more important. So what are the three basic risk categories here? One is a very high risk category wherein there is a fracture within the last 12 months, multiple fractures. In this group of patients, the preferred treatment is a PTH analog like a teriparatide or romosozumab, which is not readily available right now, and then alternative is a denosumab or biphosphonate. In a high-risk category population, which is most commonly postmenopausal females, prior to a fracture or a T-score which is less than -2.5 or a FRAX probability of more than 20%, the first preferred choice is denosumab or a biphosphonate. And in low-risk categories, it is either HRT or raloxifene or biphosphonates. So let us see what is this new molecule denosumab all about. It is a RANKL monoclonal antibody which binds to the RANKL ligand and selectively prevents it from activating the osteoclasts and thereby reduces the bone resorption. So this was the first landmark trial, the Freedom trial, in which they had two groups. One was a placebo group, one was a group in which they were given denosumab 60 milligrams subcutaneous at the interval of 6 months for a duration of 36 months. At the end of that 3 years, they saw that the absolute risk reduction was more than 4.8% for vertebral fractures, new vertebral fractures. For non-vertebral fractures, was absolute reduction was 1.5%, but for hip, it was only at 0.3%. So at the end of that, they thought that why not continue this and do an extension study and convert all that placebo group patients or trial subjects into denosumab and give them denosumab as well. And this trial was continued for a further period of 7 more years. At the end of that, there was a substantial long-term BMD increase of 21.7% in the initial group, and the crossover group also had a significant increase of up to 16.5%. That is very significant. So to conclude, from the extension trial, we come to know that there are very low adverse effects of denosumab. The low fracture incidence compared to or that observed with other during the original trial, and the BMD continues to increase without a plateau. That is more significant here. So these are the other studies that are now coming up, proving that denosumab has a primary role in medical management of osteoporosis as well. Basically, before this, the denosumab drug was mainly used for GCT and ABCs. Okay, it was introduced to improvise the tumor handling capacity, and then later on it was realized that it has a very good potential for treating osteoporosis as well. So what about teriparatide? It has already been in use for more than a decade. All orthopedicians love it. It is a recombinant human PTH. It is an anabolic agent, first clinically useful bone formation agent. It has to be given subcutaneous injection, a daily format. It has to be refrigerated. It is indicated for patients for high risk of fracture, postmenopausal women, men with primary or gonadal osteoporosis, and men and women with osteoporosis associated with sustained glucocorticoid therapy. But the problem here is the treatment is limited to 2 years, and it has to be followed up with an anti-resorptive agent further. So the first trial was fracture prevention trial. It was done in postmenopausal women, and it had good results that reduced the fracture risk was reduced by 65%. So point-to-point comparison of denosumab and teriparatide is that the most significant thing is compliance. Denosumab has to be given only once in 6 months in a subcutaneous manner. It can be given as a OPD basis as well. Teriparatide has to be given as daily injections, and that is where the compliance problem comes up. Both of them have rapid BMD gains, but the most rapid BMD gain in the initial few months is with teriparatide. 10-year efficacy data is available for denosumab, whereas teriparatide is to be given for a maximum period of 2 years with a drug-free interval later on. Denosumab can cause hypocalcemia, whereas teriparatide can cause hypercalcemia. So why not combine them? Okay. So this is a trial which is coming up. AAC does not recommend it yet, but yes, we are having promising results, wherein if you combine both of them, we have added benefit, and the BMD increase is much better than individual drug alone. So here we see that the combination has concomitant teriparatide and denosumab has increase in BMD with no added adverse events. So initial 1 or 2 years you can give teriparatide followed by denosumab. This is a switch trial, or denosumab followed by teriparatide, or a combination followed by denosumab. So the results are very interesting here. So if you see the maroon graph, when you give denosumab first and then switch it over to teriparatide, there is a big drop in BMD. So this is not to be done. I always try teriparatide first followed by denosumab, or try a combination and then continue with denosumab after the 2-year interval for teriparatide is done. So what about sequential therapy? Sequential therapy is also acceptable. So initially, most of the patients are put on biphosphonates, and then if you have a higher risk or a BMD is less than 2.5, they are put upon teriparatide, and then at the end of the 6 months, you can start with denosumab as well. So overall, there is an additive effect. What about the side effects? Denosumab does cause hypocalcemia, and that is why we should prescribe vitamin D and calcium, and it has to be properly followed up. To conclude, so the indications for use are, it has to be started with in patients of women with postmenopausal osteoporosis, in glucocorticoid induced osteoporosis, men and women, and it increases to a higher BMD. Okay. So the dosage and duration is pretty simple: 60 milligrams subcutaneous every 6 months into the thigh, abdomen, or upper arm. They should be adequately supplemented with calcium and vitamin D. Duration, optimal duration is yet to be understood, but safety trials and data is available for a duration of around 10 years, and the therapy is generally well tolerated. Precautions: hypocalcemia and renal impairment. Even though denosumab is told to be the safest drug for renal impairment patients, yet in severe renal impairment where the clearance is less than 30 ml per minute, or patients requiring daily or alternate dialysis, one should be skeptical. So to conclude, it is the only approved drug in its class. It will be followed shortly by romosozumab. Parenteral administration is the way. It reduces vertebral, non-vertebral as well as hip fracture risk. It increases the BMD more than biphosphonates. It is in combination much better than teriparatide alone. It has a continuous and sustained BMD increase over years, for example 10 years at least. The only drawback that is being seen in recent trials is that when you stop denosumab and if you don't add a drug after that, there is a sudden drop. So it should be supplemented by a second anti-resorptive or an anabolic agent if possible. Thank you.